Good evening and welcome everyone. This is Doug Parry. I'm the publisher of Ophthalmology Management. On behalf of IRIDEX Corporation, I'd like to welcome you to tonight's webinar titled IRIDEX MicroPulse Laser Therapy for Macular Edema in Multiple Etiology, an essential asset for a comprehensive practice. Since its founding in 1989, IRIDEX has become a worldwide leader in developing, manufacturing, and marketing innovative and versatile laser-based medical systems, delivery devices, and consumable instrumentation for the ophthalmology market. Headquartered in Mountain View, California, its products are distributed globally to over 100 countries. Among the innovations that IRIDEX has brought to the forefront include their patented MicroPulse technology used for the treatment of retinal disorders and glaucoma. I am pleased to introduce you to our panel for this evening. Dr. Mahootchi is the medical director of the Eye Clinic of Florida in the Tampa Bay area. His practice includes medical retina, glaucoma, and cataract surgery, and he will moderate tonight's webinar. Dr. Brandon Phillips specializes in comprehensive ophthalmology at Carolina Vision Center in Fayetteville, North Carolina. And Dr. Jason Friedrichs specializes in cataracts, diabetic retinopathy, macular degeneration, refractive error, and corneal dystrophies at the Friedrichs Eye in Sycamore, Illinois. Before we begin the program, we have a few housekeeping issues. First, if you somehow find yourself disconnected from the webinar, you can log on again using the directions provided to you for accessing this webinar. Second, if you need technical support during the webinar, please let us know by way of the Q&A box and someone will reply to you promptly. At the conclusion of our presentation, there will be a live Q&A. Please note that there will be a brief pause before the Q&A session begins. If you would like to ask a question, please use the question box on your screen and click send at any time throughout the webinar. Without further delay, let's begin the program.
Thank you for that introduction. Macular edema is a common cause of vision loss from several different eye conditions. In the past, continuous wave lasers via the thermal effect were a common but side effect prone way to treat edema that wasn't central. Then anti-VEGF treatments came along and we were able to treat foveal involving edema, but cost and compliance were big issues and continue to be so. Tonight, each of us are going to present a few cases that showcase a technology that's new but poorly understood by most ophthalmologists, MicroPulse laser therapy. I started with MicroPulse in 2013 and currently I use it for diabetic retinopathy, vein occlusions, and central serous retinopathy, pseudophakic CME, and even wet AMD. In 2013, I was looking for a new laser, and I was considering combination units but wanted to avoid one-trick ponies that just did SLT, for example. I just wanted to do more than what I could do with my conventional argon, and I found something that allowed me to do more, so I got the IQ577. I can use it as a continuous wave laser, so I can do prophylaxis of tears, cut trap sutures, etc., but it allowed me to do something that I couldn't do previously. It allowed me to treat more patients than other lasers, even subthreshold lasers, because we can treat transfoveally. So if vein occlusion patients or diabetic patients had edema just in the fovea, I could treat that. I could go right over the fovea. We can treat the fovea safely because of the MicroPulse technology. It treats conditions that other lasers can't treat, like central serous retinopathy, wet AMD, or pseudophakic CME, so I can treat more patients. And MicroPulse treats without the side effects of thermal laser. You don't get the microscotoma that you get from the burns of even the lowest power continuous wave lasers. MicroPulse reduces injection treatment burdens for macular edema and other disorders, so it frees up your time to do other things and patients' time to do other things other than getting injections. What is IRIDEX MicroPulse technology? Well, it's a technology that finally controls thermal elevation by chopping a continuous wave beam into an envelope of repetitive short pulses. On the slide on the left, we see where we turn on the laser power is on all the time. And in the MicroPulse version of that, the laser is only on for a fraction of time. So it can be on for only 5% of the time, 10% of the time, or 15% of the time. And then you have a long relaxation time in between. It's more off than it is on.
So these repetitive short pulses permit the tissue to cool between the pulses and reduce thermal buildup. Basically, the distance between the two pulses time-wise is longer than the thermal relaxation time of the tissues, so the tissues simply don't heat up.
So how does MicroPulse work? Here's a study by St. Luke's International Hospital in Tokyo. Dr. Akoshi and colleagues treated cultured RPE cells with continuous wave laser on the left and IRIDEX MicroPulse on the right. They're using the same power for both, but on the continuous wave laser side, we see thermal damage well in excess of the size of the laser spot. This is a 200 micron laser spot size, but we see a burn, the red, that's much bigger than the laser spot. Around the edge of the burn, we see the tissue that's damaged, but not dead. And it's this tissue that gives continuous wave laser its benefit. It generates heat shock proteins and other things that can be valuable to the healing response. So on the right side, we see the same laser, but done at 15% duty cycle, and you see no dead cells within the laser spot, but all active cells that are producing the desired healing proteins and local growth factors that generate that response. So that's the key difference between regular lasers and MicroPulse. We're really not trying to coagulate anything. We're just trying to induce a biologic response only. Here's another slide from the Inagaki data. The green is where there is production of heat shock protein 70 or HSP 70. On the left, you can see that the area of production is in the edges of the thermal burn from the continuous wave laser. The cells in the middle are dead and can't produce it. On the right, we see heat shock protein produced everywhere that the laser treats and essentially nowhere that it doesn't treat. It's the same energy on both sides, it's just divided in pulses with MicroPulse. So you get all the desired effect without all the undesired effects of burns.
Here's another comparison of laser treatment of cultured retinal cells. The cells are 3 hours post-continuous wave laser. Here, we see the edges of the treated area being the only area that is metabolically active. The center is where the laser was applied, and those cells are dead. The edges way past the burn is where the heat shock protein or the healing response is being produced. Now the comparison. The left side is the continuous wave laser. The right side is the same power and spot size, but in micropulse mode. And you see there are no dead cells, just the cells that are producing the heat shock protein directly where the laser was applied and nowhere else. We haven't killed anything, and we induce those cells that are already there to produce the healing response.
MicroPulse laser treatment parameters and patterns are different from continuous wave treatment. A lot of people have questions, so we'll go ahead and get them out of the way. But we treat with a different spot pattern than traditional laser. We're treating confluently, so there's no space in between the laser spots because we want all of the tissue to produce a healing response. We treat an area that's bigger or larger than the edematous area, and the effect usually is minimal until about 3 or 4 months after the treatment. It takes a while for this stuff to kick in. So whether you're using the yellow 577 or the green 532 laser, the slit lamp spot is the same at 200 microns. We usually use a 1x magnification contact lens, and the duration is about 200 milliseconds, and the duty cycle is 5%. We don't usually go above 5% for foveal treatment, so we're typically using between 300 to 400 milliwatts calculated from a continuous wave test spot. Many people give up doing the test spot after they get familiar with doing the technology. Low power but high density applications are the norm. There's a lot of published literature on MicroPulse, especially regarding safety and efficacy. Here's a short list of 45 published studies. You'll see prospective, randomized, controlled case series, and retrospective studies listed here for a variety of conditions. You'll also see some of the biggest names in ophthalmology and some great peer-reviewed journals. If you'd like more, the IRIDEX website has about 150 presentations that have been done around the world at meetings and smaller case series, but there's lots and lots of literature, and I encourage you to look at those studies on the IRIDEX website. So this is my first case about diabetic macular edema, and this is one of the first cases I did with my laser when I got it in 2013. She's a 70-year-old white female with a non-insulin dependent diabetes and a history of previous focal for macular edema. Her control's been worse with a hemoglobin A1C of 8 to 9. She works as a legal secretary, and her computer vision is worse, and her reading speed is slowing. She still has 20/25 vision, and her exam shows the macular edema you see there on the OCT. She doesn't smoke. She tries to exercise. She takes 20 milligrams of lutein for over 10 years. So she's doing what she can. So here's her baseline OCT again on the left, and we did one treatment with the 577 MicroPulse, and you can see 43 months later, her vision's 20/20. The edema is mostly gone. She hasn't required another injection. Her sugar control, incidentally, remains terrible. So in the 43 months, we've seen her vision improve. She doesn't have any side effects. She's back to work reading as fast as she could before her problems. And as we said, the A1C remains terrible, but the OCT looks good. And the take-home message is that this is early on, so I treated right in the center of the fovea, and that's something you can't do with a Trident. And look at this great result. The nice thing is this treatment can be repeated. So here's another one. A lot of comprehensive ophthalmologists, general ophthalmologists probably run across this. It's a 68-year-old white female who's got poor vision from excessive YAG pits done from a poorly done YAG capsulotomy somewhere else. She's had chronic iritis from a haptic that penetrates her iris. This is basically a surgical misadventure from before. So I do an IOL exchange with a limbal relaxing incision and a limited parseline of vitrectomy in 2008, get a 2020 result. 7 years later, she presents with an intermittent gray spot in her central vision, and her vision is 2100 with cystoid macular edema by OCT. So we did one Avastin initially, and we didn't have any resolution, and then I did one round of laser. So 1 month after the Avastin, you see nothing's happened. And 2 months later, I'm demoing a different OCT machine that you can see that the edema is gone. And the vision's 20/20, which is very nice. So 6 months later, she comes back, and I'm checking her. She's 20/25 and asymptomatic, but I see on OCT a mild recurrence of the cystoid macular edema. I repeat the treatment. I'm going transfoveally, and the vision returns to 20/20, and the CME has resolved, and the OCT remains normal for a year and a half since we did the procedure. So really nice result, way to make lemonade out of the lemons, so to speak. So this is a third case of mine about CME, or cystoid macular edema, and she's a 63-year-old white female that had LASIK 20 years ago and developed an ERM and has a vitrectomy in 2014 and gets the typical cataract afterwards. So she came to me and she wants the cataract out but wants a presbyopia correcting lens. And I look at this and you can see some of the remnant membrane or some of the results of the surgery there with an irregular contour. So usually we think twice about worrying about CME after the surgery. And so I pre-treat her with non-steroidals, and this is what I get. 1 month later, she's doing great. She's 20/30, and 3 months later, she's 20/25, and her near vision is 20/50. I believe she had crystal lens. There are no glasses for distance or intermediate, and she's only using the readers 10% of the time, and that's what her fovea looks like. It's not normal, but she's doing pretty good. So 5 months later, I see her, and she's 20/25. She's asymptomatic, but has some CME by OCT. So I go ahead and do the treatment, apply it over the center of the fovea and a little more. And 2 months later, she's 20/25, never wears glasses at all for any distance. And the OCT shows one small cyst that later resolved and has remained resolved for 2 years afterwards. So really, really fortunate result where things could have all gone wrong.
When I was doing my homework about the laser, I had overheard some international docs talking about treating wet AMD to reduce injection burden. So here's a case of mine. This is a patient who lost one eye to wet AMD 10 years ago, and this is his fellow eye that you see here. We put them through smoking cessation. They were on Preservision. They were on separate lutein. They were on fish oil, as per all the studies, doing all that we could to slow the disease down in the remaining eye. And they still developed wet AMD in the right eye here in 2010, and they have 31 subsequent injections. The intervals had become shorter and shorter, and what was a 2-month interval had become 6 weeks, then became 4 weeks, then 3 weeks. And atrophy and slowed reading are becoming issues that the patients could tell me about. The vision is 20/40, but they feel like they're working harder to read. A front page that took 5 minutes to read was now taking 6 or 7 and longer. It's just a lot more work to read. To save the one good eye of this patient with recurrent fluid who was starting to see things going downhill, I did a 577 micropulse at 5% duty cycle in January of 2014. The fluid remained by May, so I repeated it one more time, and by September 2014, the vision had improved to 20/25, and the patient had no more intravitreal injections in the next 9 months and had only one injection in 2015 and one in 2016. Unfortunately, the patient died in 2016, but going from every 3 weeks of injections to barely once a year in the last few years of your life is a home run in my book. There are a lot of reasons people drop injections. One is cost, another is frustration. People have things to do besides coming to see you every couple of weeks. There's tachyphylaxis, and sometimes patients don't have alternative agents on their insurance. So side effects from injections like atrophy seem to be commonplace after a few years of injections. I frequently see atrophy after the 20th injection or so. Atrophy can be just as bad as wet AMD for visual function as it slows down reading speed. The small scotomas in the central vision take pieces out of the picture. That's me on the left, and that's me with the blurred spots on the right. You can make me out, but your brain has to fill in the spots of the missing information. And this is just as bad for the vision no matter what the cause, whether it's geographic atrophy or atrophy secondary to chronic anti-VEGF drugs.
One of the most interesting things about MicroPulse is that you can actually increase retinal sensitivity without damage. This is a prospective masked and randomized clinical trial by Vajosevic and et al. They compare standard ETDRS continuous wave treatment to MicroPulse treatment. And we can see the microperimetry, fundus autofluorescence, and OCT on the left of the standard treatment, and the same for IRIDEX's MicroPulse treatment on the right. You will see all those white spots where the laser was applied on the left with the continuous wave laser. And you can see the OCT is better, but you'll see up at the top the microperimetry where the laser spots are applied, you will have loss of retinal sensitivity. So you're obviously creating those little burns, so to speak, and you will not be able to see as bright a light in those spots. The interesting thing about MicroPulse is that you see the same efficacy with regards to edema reduction by OCT on the right. But with MicroPulse, you can't see the treatment by autofluorescence. You'll actually see increased retinal sensitivity on the microperimetry. So this really goes to show you the mechanism of action is really different from thermal burning. Here, you're applying the laser, you get less edema, and you actually get better retinal sensitivity over the areas you treat. Reducing injection burden is important in a lot of diseases, not only macular degeneration, but in diabetic macular edema. And this is a really good study done by Morrison, Finda, and some others that show comparison between combining MicroPulse and anti-VEGF treatments to just anti-VEGF treatments alone. In group 1, they have a few patients that get MicroPulse and then get Lucentis, and then they also have a subgroup that gets Lucentis, then MicroPulse. So they do MicroPulse either before or after Lucentis. In the group 2, they do it the traditional way. They just use Lucentis. And you can see in these patients that receive the combination of MicroPulse and Lucentis, there's a 60% reduction in the number of injections compared to just using anti-VEGF in the next year. This is really, really important because it helps patients, it helps doctors, it helps payers. Everyone is a winner here except maybe the pharmaceutical company. So this is a really fantastic improvement for the patient and your office efficiency.
So that's it for my presentation. So up next, we've got Brandon Phillips from the Carolina Vision Center in Fayetteville, North Carolina. Take it away.
So I've been using MicroPulse for around a year and a half now. I actually got started by doing MicroPulse laser trabeculoplasty for glaucoma patients. I had such good results that I decided to try it for retinal diseases. And I quickly learned that MicroPulse will change the way that you practice. A comprehensive ophthalmologist will definitely change how you practice. It's definitely something that you will use every day and definitely not just on occasion. So I have a few cases that I'd like to present to you here. My first case is a 68-year-old white male, the history of a BRVO approximately 2 years ago prior to initial presentation to me. He underwent several Avastin injections at that time in, I believe, it was 2014, and he was eventually lost to follow-up. He presented to me in 2016 complaining of cloudy vision. His vision was around 20/80, and his OCTs are above. The one on top was his last visit at Carolina Vision Center in 2014, and the one below that is his initial visit to me in November. So initially I had planned to perform an Avastin injection, but he had such a bad experience with the first set that he had that he really wanted to try anything else if at all possible. In fact, he was considering just not getting any type of treatment if injection was the only thing it had to offer him. So at that time I decided to give MicroPulse a try. All right, so 6 weeks later, his vision had improved to 20/30. At a presentation, it was initially 20/80. So he had a significant improvement in his vision, and his OCT here at top, you can see that there is a significant improvement in his edema. 3 3 months later, the OCT below, his vision maintained at 20/30, and overall he was doing great. And he was extremely grateful that he did not have to receive another injection. Overall, he was an extremely happy patient. All right, so case number 2 is a 34-year-old black man with a history of CSR. His first episode was in 2012, which lasted a little bit over 6 months, and he actually lost 2 lines of vision. He presented to me with his second episode in 2017. Given his history of vision loss from previous episode and how long it lasted, I decided to treat at his initial presentation. It had sounded like it had been going on 2 or 3 weeks prior to coming to me. So I decided not to observe at that time and go ahead and offer him MicroPulse, which he would definitely wanted to do. And so I treated him at that initial visit. I did not say this with the case before, but when I use MicroPulse, I pretty much use weird parameters with every treatment. So if you see the OCT was his presentation when he presented to me. A month later, his vision had improved to baseline, and his OCT is as you can see it there. So I don't normally see patients back so quickly after I treat, but this was one of the first cases of CSR that I treated, and I just really wanted to see the results, and he was extremely happy. So prior to having MicroPulse, I really wouldn't have had much to offer this patient other than observation. If that didn't resolve, send them to a retinal specialist. I don't have PET in my office, but even if I did, MicroPulse is definitely an easier procedure. It's much easier. It's better for the patient. The recovery is quicker, and I just think overall a better option. All right, so case 3 is a black woman in her early 30s with moderately controlled diabetes. At the initial visit, she had visual acuity of 20/50 in the right eye, 20/30 in the left. She had moderate NPDR, and she had mild edema. So at the initial visit, the way I decided to treat her was I actually did do an avastin injection in both eyes initially. And then I followed her up a couple weeks later and went ahead and did a MicroPulse treatment in both eyes. All right, and as you can see, I saw her back around 3 months later, post the MicroPulse treatment. Her vision had improved to 20/20 in both eyes, and edema was essentially resolved, and she didn't need any further treatment at that time. The patient was extremely happy, and just, continued to follow her up, but she didn't need any further treatment, which is, awesome. The MicroPulse, oftentimes, the effect of the MicroPulse will last much longer than the effect of just the one avastin injection. Likely, if I hadn't performed the MicroPulse treatment on this patient, she probably would have had multiple injections. But I think because of the MicroPulse, it allowed me just to perform the one injection, and she was stable 3 or 4 months later. Excellent vision. All right, so quickly, my final case is a 52-year-old black male with a history of mild NPDR and mild DME. He's excellent controlled diabetic now. A1C is in the mid-6s. He was previously, several years ago, poorly controlled. And at that time, he did undergo a focal laser in his right eye, somewhere around 4 to 6 years ago. I can't, not sure exactly, but somewhere between 4 to 6 years, he did have a previous focal laser. So when he presented to me, his visual acuity in that right eye was 20/25. So I decided at that visit to go ahead and perform, after talking with him, different options. Go ahead and do MicroPulse at the initial visit. So the initial visit was in July. He underwent the MicroPulse. I saw him 3 or 4 months later. Vision had improved to 20/20. subjectively it was better. And this is an OCT from November, a few months later. Edema was completely resolved, and then last one is actually from a couple of weeks ago. Patient's still doing great. Edema is completely resolved, vision still 20/20, and he was extremely happy. All right, physician expectations. Patients, MicroPulse does take time to work. It's not something that's going to work overnight. So when I said I usually don't see him back at a month, usually once I perform a MicroPulse treatment, I'll see him back 3 months later. Because I know, sometimes it can be like watching paint dry. If you see him back 2 weeks later, 4 weeks later, you might not have gotten the result that you expected, and you may be a little bit disappointed. So, that's just important to remember. Second is that you may initially undertreat. In fact, if you're anything like me, when you're getting used to doing something for the first few times, you most likely will undertreat. And don't let that, if you don't get the results you expect initially, don't let that discourage you. As you use it more, you get better at doing it. It's also important to remember that patients have no discomfort, completely painless, and also important, and for patient comfort, their vision essentially returns to baseline prior to leaving your office. So really 10 or 15 minutes after the laser, their vision is what it was when they first came. And one last point is that subjectively, even with the OCT doesn't look much better, patients often will report an improvement in their vision. Occasionally, even if their visual acuity doesn't improve that much, they'll just report that, their vision just seems better to them, which is, pretty exciting. All right, so getting started with MicroPulse. Like I said, my first slide, I initially probably did 400 to 500 MicroPulse laser trabeculoplasties before I ever started using it for retina cases. I have a retina specialist that I work with, so initially he just kind of told me about what MicroPulse is, that there was an option for doing it MLT. Initially, at that time, I was doing ALTs and SLTs. I decided to try it. I fell in love with the MLT. It's extremely easy to do. There are essentially no complications to MLT. Out of about, not quite 800, close to 800 cases now, I've had 2 cases of iritis, and they were both extremely mild cases. No pressure spikes, and essentially no other complications. It's really a procedure essentially without any complications. There's only benefit from the MLT. So my first retina cases, and who I would recommend choose as your first retina cases, patients with very mild edema, patients who don't necessarily refuse injections, but they would like something else other than an injection. They would like, to try something else. They've had a prior bad experience with injection. They're very sensitive, very low pain tolerant. Those are great MicroPulse patients. Often those patients will have poor compliance. And the great thing about MicroPulse is that the effect from MicroPulse really lasts for a long time. So if you have a patient with mild edema, you might not see him again for 6 months, MicroPulse is a great option. All right, so benefits to the practice. Versatility. The MicroPulse laser, like I said, it will change the way you practice. You can do it for so many different pathologies, glaucoma, so many different retina uses. You will use the MicroPulse every day. It will reduce how many injections you do, and it actually reimburses better than injections. It improves patient compliance when MicroPulse works, and you can decrease patients getting injection after injection after injection. The patient's happier, they're much more compliant, and they really appreciate what you do for them. And like I said, it is reimbursed pretty good. But another thing that I love about the MicroPulse laser is it's actually pretty portable and it's very durable. So I have the main office and 2 or 3 satellite offices, and I actually will carry the MicroPulse laser with me to the different satellite offices. So I can do MLTs, I can treat diabetics, vein occlusions at these outlying clinics because the laser is extremely portable and it's very durable.
Well, thank you, Brandon. I have to agree with you 100% on all your observations, and especially with the glaucoma and saving money for the practice. So that was really great. Next up, we've got Jason Friedrichs of Friedrichs Eye in Sycamore, Illinois. Take it away.
Thank you for that introduction. I have been using MicroPulse since I opened my own practice almost 2 years ago. And at that time, I had experience with other different sub-threshold lasers, which obviously are different than the MicroPulse. But I was looking for a laser that was very versatile and could treat a multitude of diseases. You've seen all the different cases, and I have some similar cases that will exemplify how versatile it is. But I also want to say before we get into those cases, because we'll be talking about the MicroPulses, that I do use it for straightforward proliferative diabetic retinopathy in a continuous wave format. The platform that we have is one of I believe it's the fastest scanning laser for PRP, so it actually functions as that in my office quite regularly. I use it for vein occlusions. I use it for CSR very similarly to our previous speakers. I use it for pretty much every form of CME, whether it's macular degeneration or from diabetes. And I also use it as an MLT in my office. I have enjoyed the fact that it extends in the time between injections and reduces injection burden on all of my patients that I've used it on. And you'll see that in some of my cases. It, like previously stated, is a very repeatable procedure for CME, for glaucoma as well. And because of it being able to treat all of these different diseases, it's probably one of the most versatile lasers out there. And all of my patients, because of these factors and the decreased injection burden, are very satisfied when we do perform this laser. This is the first case that I chose to show the versatility of the laser in my office. We've seen a previous case of CSR, and this is another one. But this is a gentleman who is 44 years old with no history of steroid use. He does have good visual acuity in the affected eye, but he has metamorphopsia that is very bothersome for him, as he is a financial businessman who works on computers all the time. And it is very bothersome to him, and it causes him a lot of grief. He's a very typical type A personality. And he came into my office to see if there was something that could be done to help with this. As you can see on the angiogram, there's a very typical double smokestack configuration of this left eye. And what we notice is that it's very centralized. But there is very minimal fluid. In previous cases like this, we probably would just watch it and not offer any treatment because it is subfoveal, and it would be very, very difficult and dangerous to try and treat those with a typical coagulation type laser. He had a treatment with the MicroPulse, a grid laser treatment performed in November of 2015 and March of 2016. We'll see in the next slide how things look after the first treatment. You can see here that after the first treatment there wasn't much change, and he was still complaining of metamorphopsia. So he underwent a second treatment, and 3 months post the second treatment, you can see there's complete resolution of fluid, and he has no complaints of metamorphopsia, and his visual acuity has been maintained with a foveal treatment of the CSR. This next patient is a 46-year-old gentleman who was a very non-compliant diabetic in his early years.
and has since became quite compliant. In fact, his A1C I don't think has ever been above 7 when he's been in my office. But you can see that this gentleman has chronic macular edema. He's had proliferative diabetic retinopathy in the past, and he is just a patient who is in the past received so many injections. You can see his vision's not very bad. His central macular thickness is pretty elevated in both eyes. And prior to November of 2015, he basically had 3 years of monthly injections of every anti-VEGF drug known. We would switch in order to try and elicit a better response. And he had multiple subthreshold continuous wave grid laser sessions. And he, despite that, still had chronic CME. He had MicroPulse grid laser treatments in my office on several different occasions, and 2 treatments in the right eye and 1 in the left. These slides show the central macular thickness has come down quite a bit since that initial presentation. And since those MicroPulse treatments in each eye, from November of 2015 to May of 2017, a 1.5-year period, he's only had 4 injections in each eye. That just exemplifies the decreased injection burden for these types of patients that we would have been injecting every month and possibly causing chronic atrophy and decreased retinal function. And so decreasing that burden with this patient, I think, probably will make a very big difference in the.
Hey, Jason, this is Ahad. Wanted to just chime in. Do you notice that any pattern to the reduction? I've noticed, at least in my practice, it seems that in a third of patients it seems to double the injection interval, and maybe in another third you get to the 1 to 2 a year kind of scenario, and then in the other third you seem to eliminate it for a year or 2. I don't know if you see that same pattern or not.
I think it definitely depends on the chronicity of the patient. And I would say in general, at least my injection burden goes down by a third, at least, at a minimum. And I think that's a conservative estimate.
Yeah, when I first started, I could tell by the money I was spending. I was spending something like $42,000 a month on injections of all different kinds. And after getting the device, it went down to 14 for a couple of years. So I knew I had to cut it by 2/3, at least in my practice. But everyone's practice is different. But I think that kind of is a testament to, if you have to show me the money, that definitely shows me I'm using definitely less injections.
Well, from a financial standpoint, I can't remember the last time this year that I've used an EYLEA injection on a patient. So that in and of itself, should say that since I've introduced MicroPulse laser therapy, that I just haven't had to use other types of anti-VEGF. I'll still use the VEGF injections, initially to get, central macular thickness below 400 so that I can treat with MicroPulse. I think we've all said that we get a better response below that. There's been some studies that have shown that. So VEGF still has a role in helping these patients initially, but I definitely have spent less money on not having to utilize the more expensive anti-VEGF injections.
Thank you.
This is the last case that I'm going to present. This is a case of an 85-year-old female who is one of the oldest patients in my practice, not by age, but by length of treatment. She was a patient who had been getting injections every other month, basically, for 5 years, prior to August of 2015 in her left eye. She didn't have a really thick central macular thickness, but without injections, her CME would reappear regularly. She was one of the first patients that I treated for this type of CME pattern with AMD, and you can see she had 3 separate laser treatments there. You can see in this last slide that I'm not trying to show that the disease is gone from MicroPulse therapy. But what is the most amazing thing is that, in a lady that had been having that many injections post MicroPulse therapy, she's had 4 injections in over 1.5 years, and that's it. And it's maintained her visual acuity at 20/25 in that left eye, and her central macular thickness is even better. There's no significant atrophy either. You can see that she still does have a normal foveal contour, which in the long run, I think we all know will give her better visual function. This slide shows my typical treatment parameters for a MicroPulse laser session. The nice thing about the treatment parameters for this laser is that they are all in presets in the laser console. There are presets for MLT, for PRP, for focal laser, for MicroPulse session that are all easily accessible and quickly configured. My typical treatment parameter for a MicroPulse session is shown here, and just like the other speakers, I use a 200 micron spot size, 200 milliseconds with energy delivery of 450 milliwatts. I use a 5% duty cycle, and I use the largest grid size as well, a 7x7 with 0 spot spacing. A session like this will take under 5 minutes to perform on a patient. I, as a physician running my own practice, am very financially conscious of everything that I do. I feel a big responsibility to my community because I do practice in a small community, and that I want to make sure that I'm providing them with a effective treatment that's cost effective, that is time effective for them. And I know we've said this before, but this laser really does make a big difference with the diseases that we treat. Now, the patients really do appreciate the fewer injections. The amount that they have to come into my office is much less, and henceforth will miss less work. And obviously, we know patients are very anxious about injections, so the least amount of injections that they can have, the better. I think also financially it's less because, the deductibles, it's a procedure, and so these procedures go against our deductibles, and if you're doing a procedure every 3 months or even less, if you can get them to respond to the MicroPulse laser, then they have less deductible to pay. We win as physicians as well. We've heard that. Fewer injections allows us to open up more time slots in our practice to get patients in and cut down our wait times for new patients to be seen. I think that the least amount of injections you're doing probably lowers your risk profile from an infection standpoint. We do know it's a very small number, but when it does happen, it's catastrophic to patients. We've heard the decreased expense of purchasing anti-VEGF, and I know that I've seen that in my practice. As I stated, that I basically can't remember the last time I've purchased EYLEA for patients. And like I said before, increasing your practice availability to the community, especially in a small community like mine, is very important. Not only that, but we win in the sense that it is more profitable for you to be doing lasers rather than injections. From a time cost standpoint, it's better. The reimbursement is better for us than it is to do an injection from a procedure standpoint. The insurance companies, I know we don't want to say that. We don't want to say the insurance companies win, but they do. And, if we do let them, feel good about this procedure, maybe they won't cut our reimbursement for it as well, which we're all tired of. But MicroPulse is preferable even to them to monthly injections. I mean, we know the cost of injections is $1,800 for the FDA-approved ones. And if you're doing that on a monthly basis for a lot of these patients that we had shown that we had converted from monthly patients to much less, the cost savings to insurance companies is great. And not just private insurance, but Medicare as well. And I think, we have to be conscious of the amount of money that we're taking out of that program. The other thing is that the CPT code for these treatments already exists for all of these diseases. It's simply the CPT codes that we've been using for diabetes, for focal, and for PRP. And you don't have to change anything. You don't have to reinvent the wheel to code these things and get reimbursed for them, even though you're treating multiple different diseases with this laser. And I've said this over and over, but when we take less money out of the societal bucket, I think that is our jobs as physicians. This needs to be done, and we need to be thinking about it. Just because we have an FDA-approved drug that's $1,800 doesn't mean that we should be using it. If there's an alternative therapy that is beneficial to everyone involved.
All right. Thank you, Jason. That was a great presentation. Now we want to open it up to the participants in the webinar. You can type your questions in the box over to the left, and we'll be happy to take them. Great. I can see questions already submitted. Thought those were great case presentations from both you guys. I guess we can just get started with the questions. I see a great question from Dr. Achin from Pikeville Medical Center. He asked, if the patient fails the first treatment, when do you consider repeating? And when you repeat, do you consider increasing the duty cycle to 10% with other parameters unchanged? I'll let you guys comment, but originally I thought this might be an option, and if you really look at the literature, safety literature, this is probably not a good idea to increase to 10%, at least close to the fovea. You're better off increasing the power, and as I can, maybe up to 400. I know some people, Jason, you go up to 450, I believe, but most people stay under 400 milliwatts in that 5% duty cycle. I often use much less. I still do a test spot, so my treatments can vary from about 240 milliwatts to 360, and I'm frequently in that 300 to 300 or 280 to 300. So if I'm there and I don't get the response I want, I will increase. But I typically, it takes 4 months, except for CSR. It really does take 4 months to see the results. I don't know if that's what you guys think as well, Brandon.
Yeah, I agree with everything you just said. I would definitely not recommend increasing the duty cycle to 10%, and I pretty much second everything you just said. I usually stick to about 400 for power. I've talked to a couple other docs who do this. I don't know many people who go much above that, but I just have to agree. I don't think that'd be a good idea.
I also don't increase duty cycle at all. This is Jason Friedrichs, and I will just repeat the treatment at about 3 months, because I think we've seen that you can jump the gun a little bit and not see the results that you're used to seeing with typical focal thermal lasers right away. That maybe it's not just a non-response. It's just that we're not waiting long enough. But so I wait at least 3 months before retreatment for any disease.
All right, great. We'll remind the audience, just click on the Q&A button at the bottom of the presentation, and you'll see where you can type your question. The next question, I believe, is, if I turn down my power and duration for a continuous wave laser treatment, isn't that the same as MicroPulse? I think this is such a common misconception. I honestly thought this was the case as I walked by the booth in my ignorance for years, but it's not the case. With subthreshold laser, you can still see the burns. It's not doing the same thing because the laser is on longer than thermal relaxation time of the tissue, so you're actually creating a burn. It's really not the same as MicroPulse, and as you can see, even if you turn I have a slide I show at presentations where I've got the laser down to like 40 milliwatts and continuous wave, or 50 milliwatts, and you can see where I've done the test spots like that with the fundus autofluorescence, and you can turn it up to 400 and not see the in micropulse mode and not see the test spots. So they're really not the same thing, and certainly I don't think anybody dares with subthreshold continuous wave laser going right through the fovea. That's just not something you can do. But it is something that we've done. I've probably done 400 or 500 times now without any kind of deleterious effect. So that there is quite a bit of difference. I often wondered, and there's another question here about how do you know you've done anything or something like that. And I've wondered this myself when I was demoing a camera that could do fundus autofluorescence back when I was demoing with the laser, and you can see the by OCT. You can't see a burn by OCT, but you can see the disease go away, the edema go away with time. Usually within starting about 6 weeks to 4 months after the laser, but you don't see any fundus autofluorescence. You don't see anything on FA. And if you go back to kind of what originally, how does laser actually work? In some cases, you're change with continuous wave laser. You're really looking for the changes that are outside the burn. And if you saw the presentation in the early slides, you might have missed it if you checked in late. But you can see that cells that are not killed by laser, and in continuous wave, that a small proportion of the cells that's kind of at the edge of the burn, they produce growth factors. There's a great slide on the IRIDEX website that's got a bunch of different local growth factors that are produced when their cells are exposed to micropulse laser, but not others. And you can see it on the slide I presented, I think, back early on in this presentation, where the edges of a continuous wave laser have some of that, but you have the big burn to deal with. And on the micropulse side, you see the cells that are producing these heat shock protein, different kind of, I think it's TGF-beta is one. There's some other proteins that are produced all through that area that's treated and not in the untreated area. So we're starting to see the science come around showing exactly how this happens. We don't think that it's one growth factor or even two. I think you're producing a whole host of things that are responsible for healing. Jason, if you have, or Brandon, if you've got any other comments on that, let me know.
I agree. I think there's a question that kind of goes along with that as well. There's a gentleman asking about increasing the duty cycle from 5 to 10, but lowering the energy at the 10. And I think it goes along with all the slides that you've been saying, is that the goal with this laser is to elicit a healing response. Whereas, if you double the length of the time that the laser is on, you're decreasing the likelihood of having that healing response by destroying the tissue. So I think the 5% duty cycle is probably better at a higher energy, to reiterate what you said.
I agree.
We've got a question. We've got a question about continuing anti-VEGF treatment while waiting for responses, and it's not laser trabeculoplasty response, but for focal or PRP or whatever you call it. For foveal treatments, yes. I would, because it takes a while, I usually will do an injection or time the injection so that I have one to kind of float them. But after the 3 or 4 months, as I said, most of the time you're not needing to do another injection. So yeah, you feel free to make the patient happy. With something for like wet AMD, I'll do the first, if it's a new case during induction, I'll put the laser somewhere between the first and the second injection, around the second injection, so that by the time they get through the 3 initial, you're starting to see some break and not having to repeat as often.
I do the same thing as well. I'll see my patients monthly in the beginning for a new lesion, and add the laser once I feel as though the foveal thickness has come down to its maximal response, and then treat.
There's a question for the comprehensive ophthalmologist, which laser would be preferred, the 577 or the 532? I have the 577. I'll go first. I'm a type 1 diabetic myself. I don't have macular edema, but I've seen the good, the bad, and the ugly of poorly done continuous wave focals. And if you do enough of these, you'll hear somebody tell you about that microscotoma in the center of their vision. So I wanted everything that I could to protect the fovea, thinking, do unto others, so to speak. So I got the 577, but I understand people get great results with the 532 without side effects. So I don't think there's been a head-to-head comparison or even anecdotal stories of differences. But what do you guys have?
I have the 577 as well, and I purchased that just because of I thought the 577 wavelength was more versatile than the 532, just from all the previous studies, for targeting, different lesions.
We have the 577 also. The results with the MLT, the laser trabeculoplasties, are so good that I would recommend the 577 just based off of that for the comprehensive ophthalmologist.
We've got time for one more question, but there's a whole bunch of questions here.
There's one question that I think is interesting. It's how do you bill for MicroPulse laser trabeculoplasty or laser treatment if used for non-FDA approved diagnosis, e.g. ARMD? And I think that's something that we should really explain to our listeners, is that you would never use like an exudative macular degeneration diagnosis to bill the laser. You would use a cystoid macular edema diagnosis or a choroidal neovascularization as the diagnosis to bill the laser, because both of those are billable diagnoses under a focal laser treatment, which is what you're billing. So I just wanted to answer that quickly so people did know that even though it's not FDA approved for AMD treatment, focal laser treatment is for choroidal neovascular membrane and CME.
I don't think there's I'm not a billing expert, but I have heard, and I've heard multiple questions about this around, this is a hot again, and I think, I've seen it used for wet AMD. We don't use laser trabeculoplasty because, some people use focal codes, some people use PRP codes, think the number of spots, you're treating confluently, so that they think that justifies the code. I use the focal. I know other people use a PRP code, and it's, there's generally an FDA-approved device can be used for non-FDA-approved treatments, but I haven't seen any issues with billing with this. I have to say, you're saving the payer so much money. With for us, it was a couple of $100,000 a year in Eylea, Lucentis, that I don't think you're going to be on anybody's radar for spending more money. So there are a whole lot more questions up here, and I want to thank everybody for attending. If you've got more questions, feel free to contact IRIDEX, and they can probably get you some really great detailed answers. The website is amazing in how much data is there. So I want to thank everybody, Jason, Brandon, and on behalf of me, Ahad, Mahootchi, wish everybody a good night.